Okay, so welcome everyone. Good afternoon, and thank you for joining us from wherever you are joining us. My name is Brooks Roach. I'm manager of patient knowledge and connection with Diabetes Canada, and I'd like to, in addition to welcoming you all, I'd like to begin by acknowledging that I am joining this webinar from the traditional and unceded territory of the Mi'kmaq people. And wherever you're joining or watching from, I'll invite you to take a moment to express recognition and gratitude for the land on which we live and gather. We're here today to talk about diabetes in older people, including the complications and changing considerations in self-management as we age, differences that we may experience depending on the type of diabetes we live with and what stage of life we're in, and strategies for aging well for people living with diabetes as well as their caregivers. I'm thrilled to welcome two very special guests this afternoon. So first, I'd like to welcome Dr. Daniel Tessier, who is a physician specializing in geriatrics and internal medicine, and a recognized professor researcher at Université de Sherbrooke's Department of Medicine and Center for Research on Aging and Geroscience. Welcome, Dr. Tessier.
Thanks.
I'd also like to give a very warm welcome to Dorothy Bergmann. Dorothy was born in 1934 and diagnosed with type 1 diabetes in 1947, only 25 years after the discovery of insulin. Dorothy went on to become a registered nurse, among the first graduates living with T1D in Canada, worked in a family doctor's office, and as a diabetes educator, a volunteer, and the events convener in her local chapter of what was then the Canadian Diabetes Association, now Diabetes Canada. Dorothy held a number of other nursing roles and was instrumental in certifying some of the first hospital nurses for the use of the glucose monitor at the bedside. She's a mother to 5 children, 6 grandchildren, and 7 great-grandchildren, and continues to live a busy, active life, traveling the country from coast to coast to spend time with her grandchildren. She enjoys a glass of red wine, sunsets at the cabin, and is described by her family as tenacious in her self-management. So, Dorothy, thank you for all your work and volunteerism over the years, and thank you so much for being with us today.
Thank you very much for having me. It's my pleasure.
Oh, thank you. Today, our 2 experts will be answering some key questions that they have heard from patients and seen in their work and research and time living with diabetes. We'll also be taking questions from you, our viewers. So at the end, feel free to place any questions in the chat on the Facebook live stream at any time throughout this webinar, and we'll answer them toward the end of the hour. And we just welcome you to engage, share your own thoughts or stories or questions as the conversation goes. And without further ado, the way we're going to approach this is Dr. Tessier has prepared a few slides where he'll speak to the interrelationship of diabetes and aging. So he'll walk us through these slides, and then we'll open it up for a conversation with both Dr. Tessier and Diane on lived experience with diabetes. So slides should be up. Can I just get a thumbs up from you, Dr. Tessier?
Sure. Can I change slide or you change slides?
You just hit me with a next slide, and I will
have to do next slide. So, well, first, thanks very much, Brooks, for inviting me to talk about diabetes in the older population. That's been a subject of great interest for me in the last 40 years since I did my fellowship at UBC with Grady Minelli. I still owe a lot to Grady for teaching me most of what I know about diabetes in the elderly. So I say hi if he's there somewhere. I'll speak to you about what is the entity of diabetes in the elderly. So that's a brief review of the objectives, diagnostic criteria, therapeutic targets adapted to individual situations, medications, specificities, comorbidity, polypharmacy, and geriatric syndrome. I hope I won't talk more than 15-20 minutes to leave time for discussion. So next slides. So it's a graph showing the growing prevalence of diabetes in the older population. You see over 20 years, the percentage of older patients living with diabetes has more than doubled in the Western Hemisphere, and it's probably true also worldwide. So from 1995 to 2007, the prevalence has grown from 8 to 16%. And we recently made a studies in our geriatric units, and the percentage of older patients with diabetes is 20%. So it's a very common disease. We have often to address issues about glucose control, insulin injection, therapeutic targets. So that's a very important topics, disease to treat for physicians, and well, not just physicians, but also pharmacists, kinesiologists, occupational therapists, nursing. So that we all share common objective to accomplish the good management of diabetes in the older population. I made a slides about diagnostic criteria for diabetes. These criteria are mostly for type 2 diabetes. Usually we characterize diabetes for either type 1 or type 2. Type 1 is juvenile diabetes and with prone to ketoacidosis. The pathophysiology is antibodies directed against pancreas. And usually it's an abrupt starting disease with very high sugar and ketosis. Often it ends up in the hospital at diagnosis. The other type of diabetes is type 2. It's said diabetes of the older population, but we now know that the children may be affected with type 2 diabetes, children having obesity, inactivity, abdominal obesity. So it's not just a disease of older patients, it's all disease of the multiple categories of patients. And type 1 diabetes, we see more and more type 1 diabetes in the older population. First, because they live longer, like Dorothy. So we're starting to see our patient with type 1 diabetes who live more than 15, 20, 40 years after the diagnosis. And there's a specific form of type 1 diabetes in the older population called LADA, late autoimmune diabetes in the adult. So it's like in the juvenile population, but it happens in the 60s or 70s. It's antibodies against the pancreas. So we see there's a mixed population, and even the older population living long enough with diabetes, 30 to 40% of them will have to be treated with insulin, which is very common. It's not a drama. I think it's the evolution of the disease. Pancreas get exhausted for different reasons, and we have to not just stimulate the pancreas, but also to replace insulin treatment in many cases. I just put the criteria for diagnosis. So you might have been affected with diabetes and the doctor told you, well, your blood sugar fasting is 8 or your HbA1c is 7, so you're diabetic without symptoms. Sometimes it's an asymptomatic disease for many, many years. So for those who are not familiar, glycemia, everybody knows about it, but HbA1c, it's a glycated hemoglobin. That's a test that may be used for diagnosis or follow-up on treatment of type 2 diabetes. Next slide, please. So I'll make a brief summary of the Canadian Journal of Diabetes guidelines. They've been republished in 2018, and I suppose it's every 5 years. So I suppose they'll be republished next year. So a lot has happened. There's many studies on diabetes in the general population, and the CD has made a tremendous good job to summarize the recommendation how to diagnose and treat diabetes. And I heard somebody who said that the Canadian guidelines are the second or third best guidelines in the world. So about maybe 18 or 20 guidelines. So we're second or third, which is great for Canadian authors. So next slide. If you hear doctors talking about diabetes, they'll mention new studies on drugs. They say, well, I have this study in the elderly. Look, it's fantastic. This drug is working fine. But what we see is that the older population selected to participate in these studies is not representative of the whole population. That's probably an older person who will participate in a diabetic study. But next slide. What I see in the geriatric ward is mainly this type of patient. She's frail, fatigued, she has cognitive problems. So that's the usual older patient with type 2 diabetes. So we have to address these issues, how this lady should be treated, what treatment can she take, how will be supervised in the diabetes management. So that's very common questions in the short stay geriatric short stay unit. So next slide. Probably if you see your doctor, he'll talk to you, or he'll mention you, well, you have reached a goal, HbA1c goal. So the goal is usually below 7%. The higher it is, the higher the sugar is. It's like HbA1c is a product of attachment of glucose to hemoglobin. It's a reflection of how has been your blood sugar in the last 3 months. So the usual standard is below 7%. But as you get older, you get more complications. Maybe life expectancy is less. You have less capacity to recognize hypoglycemia. So your doctor may mention you, well, HbA1c of 8% is adequate for you. We won't reach for 7%, but please discuss this issue with your doctor and mention what is the optimal goal. And each patient has a set of determinants who makes the physician and clinicians, specialized nurses, to opt for different level of HbA1c. So not meaning that glucose is not important. I mean, 10, 11% is too high. I think we're talking about HbA1c around 8.5%. If you have 7%, that's perfect, that's ideal. So we'll hear Dorothy mention us what were our lifetime HbA1c goal later on. So that's a discussion that has to be made with your physician, nurse clinician, pharmacist, and you have to have kind of an agreement with all these professionals. What is your optimal glucose control for you specifically? Next slide, please. So diabetes has been associated with frailty, meaning progressive loss of strength, loss of muscle strength, and diminished capacity to walk and get mobile. So I think diabetes is a predisposing factor for frailty, and it should be looked after by doctors. Next slide. And also the management of diabetes has to be seen as a person living in a family, living in a community, living in a health system. Many patients have to see the pharmacist, nursing, occupational therapist, social worker, nutritionists are very important. So it's part of a global system, and the optimal treatment of this entity is the result of a collaboration with numerous specialists interested in this disease. So it's not just a question of drugs, but also addressing different issues like we'll mention later. Next slide, please. Nutrition is very, very important. Probably Dorothy, when diagnosed with type 1 diabetes, diet was very strict. Then weight loss was often prescribed. And it's been a very strong paradigm in the management of type 2 diabetes. What we observe now is that many patients with the type 2 diabetes in the older population are undernourished or malnourished, or if you make intervention to cut calories, go for a weight loss program, it might be detrimental. So nutritionists are very important part of the diabetes treating team. So weight loss is, if your doctor says, I don't want you to lose weight, don't be surprised. I think that's an option, even to optimize nutrition in many cases. Next slide. I'll briefly talk about drugs and pharmacologic treatment. Next slide. And hypoglycemia recognition, which is quite an important issue. As the population gets older, the capacity to recognize hypoglycemia can be impaired. And we often see patient with 3 or 2.8 glycemia asymptomatic. And when they get to 2.5, they lose consciousness. So hypoglycemia recognition is very, very important, and treatment has to be adapted. Major factor for hypoglycemic events are insulin, sulfonylurea, and problem accessing appropriate food during on a daily basis. So you see all the risk factor for severe hypoglycemia. Cognitive impairment is a risk factor for hypoglycemia. Next slide. So usually there's been a tremendous development in new drugs for type 2 diabetes in the last 10 years with the GLP-1 agonists, DPP-4 inhibitors, SGLT2 inhibitors, and new insulin. I'm sure I don't want to spend too much time talking about different drugs, but I see usually they're quite important for the optimal glucose treatment. Usually the first drug is to be prescribed is metformin. I'm sure in the audience, many patients are taking this drug, which has been there for many, many years, is well known to doctors, and has to be titrated slowly. Major problem is GI side effect when the dose is increased too fast. Next slide. So different type of medications based on physiologic, pathophysiologic mechanisms. Certain drugs may promote insulin secretion directly or indirectly. One directly is like glyphosate, diamicron. Indirectly is like DPP-4 inhibitors or GLP-1 agonist. Probably many of you take Januvia. Januvia is a DPP-4 inhibitors and prolong the half-life of the GLP-1, which stimulate the pancreas to secrete more insulin. Don't promote insulin action, like metformin, replace insulin, like insulin itself, increase glucose excretion by the kidney, like dapagliflozin, different name like Ongliza or SGLT2 inhibitors, and certain drugs are also have also the capacity to diminish the appetite, which is much less popular in the older population. So usually that's the main classes of medication used. So I made a graph of GLP-1 receptor agonists, which are injectable drugs, which are more and more popular. The principal side effect is loss of appetite and weight loss. So if it is titrated progressively, it's well tolerated. These drugs are more and more popular because they have shown the capacity to diminish the incidence of cardiovascular events and promote prudent weight loss in certain cases. SGLT2 inhibitors, which are drugs that promote excretion of glucose by the kidney. The principal side effect is genital infection due to glucose being present in the genital tract. DPP-4 inhibitor, very popular drug in the older population, like Januvia. Insulin, insulin secretagogues like repaglinide, diamicron, diabeta, sometimes is also prescribed. So that's like a global panel of different drugs used to treat diabetes, and which one to choose it should be discussed with your doctor, with your endocrinologist, with your pharmacist. So what's the best? Usually the first drug is metformin, but the second drug has to be decided on an individual basis. Next slide, please. Kidney function is quite important because it tells us to use or not to use, or to adapt the dosage of the drug according to kidney function. Usually nurses and pharmacists are very well aware of this graph, and they'll go look at your kidney function and tell you, well, this dose of Januvia should be X or Z. So, so it's a team decision about which drug and what dosage should be used. I won't go through all the drugs because they're quite numerous. Each patient has a different pharmacologic profile, but if there's a question later, it will be a pleasure for me to try to answer your question. And what about insulins? Probably when Dorothy was diagnosed with diabetes, there was 1 or 2 types of insulin. They were made with pancreas of pork and beef. The problem was antibodies, and sometime after a number of years, there was antibodies against insulin. But now we have insulin, which is fabricated by E. coli, and they're all very close to human insulin. In fact, they are human insulin, so there's much less allergy to insulin. So usually type 1 diabetes, usually treated with insulin at diagnosis, but there's a growing elderly population, as we will see with Dorothy, that are coming now to the geriatric wards with their insulin, their pumps, their glucose monitor, and I think we have to take good care of these patients, this growing population. Okay, and types of insulin. Usually there's 2 families of insulin, bolus and the basal insulin. Basal is NPH, glargine, Lantus, Levemir. So they're kind of basal insulin. There's no peak. So we usually they're to be taken once or twice a day, and they're kind of they're replace the basal secretion of insulin. And many patients will have to take over basal insulin, bolus insulin, which is also called prandial insulin, Novorapid, Apidra, Humalog, Yolin R, and there's a Fiasp also, and there's like also other new basal insulins like Tresiba, Degludec. It's a growing family of insulin. It's fantastic for clinicians who are now a large array of different type of insulin to promote good treatment of diabetes. Next slide, please. Excuse me. Insulin mixtures. We use them sometime. They're a mixture of basal and bolus for patients who do not accept to take more than 1 or 2 doses chart of insulin a day. They might be practical in certain situations, but usually as a clinician, I'm more inclined to use basal insulin and add prandial insulin depending on the daily glucose profile. Next slide, please. High blood pressure, very common, has to be treated accordingly. Many older patients also have high blood pressure, high cholesterol, have had heart conditions, amputations. So we have to treat well high blood pressure with different drugs. That could be the subject of another conference. Next slide. Foot care, very important. I think your physician should have a look at your feet when you go visit him to see if there's any deformation, callosities, ulcers, infection, poor circulation. Diabetes is a major factor for amputation, and that's a clock. Clock drawing is a good diagnostic test to detect cognitive impairment, dementia, either of vascular or Alzheimer type. Next slide, please. Diabetes doubles the risk of neurocognitive problems and has major consequences on adhesion to treatment and compliance to drugs, glycemic measurement and management, and more. And there's more frequent hypoglycemic event in the population with a cognitive problem, majorly due to poor hypoglycemia recognition. So if there's any cognitive symptoms, your doctor might ask you to do the Folstein test or the MoCA test, clock test, to detect any cognitive problem and probably adopt treatment according to if there's a diagnostic of minor or major neurocognitive disorder. Next slide, please. So just to mention that the older population with diabetes on the above, it's like a double 1.5 risk of Alzheimer's disease and 2.5 risk for vascular dementia. Next slide, please. So clinicians should assess older patients with diabetes mellitus who present cognitive symptoms needing an intervention. Next slide. And falls, which are the fact of being diabetic doubles the risk of falls due to visual problems, sensory problems on feet, orthostatic hypotension, hypoglycemic events. So in general, as a geriatrician, I have to evaluate a falling problem. So if you go to the doctor, don't hesitate to mention, I fell last week because of I tripped over something, I fainted, or I poor feet sensation and I didn't see a carpet, or I fell down the stairs, or I fell on the sidewalk, I fell outside, I fell in the bathroom because I slipped on water or soap. So don't hesitate to mention falling problem. Urinary incontinence, which is often minimized in the older population in general. So risk factor being infection, bladder hypercontractility, hyperglycemia, and polyuria. So again, if you have a urine incontinence problem, don't hesitate to mention it to your doctor, your nurse. Some therapies are available, some intervention can be done to alleviate that problem. Pain assessment, which is quite frequent, can be due to arthrosis, osteoporosis, back problem, or peripheral neuropathy associated with long-standing diabetes. Peripheral neuropathy is quite frequent, which can be of the anesthetic type or the hyperalgesic type, with often night pain on limbs, which can make also sleep more difficult. Next slide. Polypharmacy. As you see, if you have hypertension, diabetes, heart disease, lipid problem, you might end up with 6, 7 drugs. So the intervention of pharmacist is very, and a nurse clinician are also very welcome to review medication, pain medication like Lyrica or Tylenol, and should be titrated to have lesser number and amount of drugs as possible. So in conclusion, I hope I didn't take too much time. 31, yeah, okay. So the important thing is to establish a therapeutic plan, consider nutrition, physical activity, intervention to monitor kidney function, review glycemic diarrhea, and evaluate hypoglycemia recognition, screen for geriatric syndromes, and caregiver, pharmacists, nursing, optometrists, or nurse clinician, they're all important part of the team to have an optimal control of diabetes in the older population. Thank you very much.
Thank you, Dr. Tessier. I really appreciate that, and that's a real deep dive into some of the interrelationships with diabetes as we age, and I hope has given some real actionable steps to viewers. And I also want to round that out and balance that with Dorothy, your experience living with diabetes. You know, this so late in life, and as you've aged, I'm curious if you can just share what that experience has been like and what you've found has set you up for success, and any advice you'd impart on our viewers.
Well, I have to go back to the very beginning, I think, and remember when I was just a youngster in my teens, I met the doctor from the clinic in Boston, who first started treating with diabetes. Dr. Jocelyn. He wrote the manual for diabetics, and I think he would really taught us. The thing he said was learn as much as you can about your disease, about the use of insulin, and about your lifestyle and activities. They all have to be balanced, and they will be part of your life forever. They're not going to go away. You don't get holidays. You must manage them correctly, or your diabetes will be managing you. You have to be in control. And those are the things you have to do. Learn as much as you can and be as disciplined as you can with yourself as you're still trying to live a happy, full life. And I think it's certainly a challenge, but at 13, I was ready for a challenge. And then I began, the rest of my life kept right on going. I graduated from high school. I graduated from nursing. I got married. I had my first child. And that was really unusual for that early. And he was born in 1956. And that was, there weren't a lot of healthy children born to diabetics of that age and that time. And I very luckily had a very healthy little boy with a bit of a lung problem, but he is now 66 years old and he's still good. And I have had, since that time, I had 4 other children, and they were all by cesarean section. My gynecologist did not agree in putting a diabetic through labor, and knowing that the baby usually grew a tremendous amount between the 8th and the 9th month of pregnancy. So he looked at the baby after 8 months, and as soon as he found that the baby was pretty viable, the bones were good, the lungs were good, he would do a section between the 8th and the 9th month. And all my little children, excepting for one, were fine. My 4th child was not good, but I think that was because I was not in good control at conception. And that might not have been the cause. The doctor kept saying, don't blame yourself, don't blame yourself. But I do know I was in Hawaii on a wonderful vacation. I was drinking Mai Tais. And up to that point, I drank very little alcohol, but I had a wonderful time in Hawaii. And I think that might have contributed to some of the abnormalities. Like he had hydrocephalus, of course, but spina bifida, that was fixed first. And then the hydrocephalus, they put the shunts in. And I guess at about 6 weeks, maybe almost 2 months, I took the little fellow home with us because he was our baby and it was Christmas time. And he stayed home with us then for about 4 or 5 weeks. And then I took him back to the doctor, but the shunt did not work well enough. And they put another shunt in, and that didn't work well either. So the baby died at 3 months. And we were very sad. Robbie, we were very sad about that. And my children all understood as well as they could why their little brother had passed away. And then after his burial, and we got through that. And then I thought, should I ever have another child? I think I should. I think I should go on contraception, permanent contraception, whatever. Anyhow, that doesn't work in my religion. I won't get into all of that right now, but I decided that I wouldn't. And then I decided, you know what? I'm just going to leave it in God's hands. And if I have another baby, we'll accept whatever we can. And this little girl was born to me in 1934.
64.
I was born in 34. She was born in 64 when I was 30 years old. And this beautiful little girl came when my youngest daughter was 5 years old. No,
yes, she was
5 years old.
5th birthday present.
Yeah, that's right. And she wanted a Barbie doll for her birthday. And darned if my gynecologist didn't find a Barbie doll, and we brought her home to Diane. And she's healthy and she's staying with me right now. But she unfortunately is so full of energy and she works so hard, and she fell off a ladder and broke her ankle. So she's been 10, 12 weeks now that she has not been able to walk properly. And as soon as she could, she came here to help. And anyhow, that's my family. And I'm very happy that I was able to have a family. And I'm very happy I'm the matriarch of the Bergmann family. And I have 4 children and 8 grandchildren.
No, 6 grandchildren.
6 grandchildren, okay.
And 7 great-grandchildren.
And 7 great-grandchildren. And I'm still the only diabetic in my family. And I think that's really nice to be able to say. And that's one very part of my life, okay, my family. And I managed to work when I was having this family, and I enjoyed all of the work I had to do, but I always accommodated my children as I was working. And
always accommodated your diabetes control.
Absolutely, I had to know the lifestyle I had to live with, and I had to arrange my diabetes around it. I had to know when I had to eat and when I had to exercise and when I couldn't do this, and when something else happened, I had to adjust that to my lifestyle as well. So it was a matter of thinking every day of what you're doing and how you're doing it, and understanding what you're doing and doing the very best you can.
Well, Dorothy, if I may, it sounds like you very much have done the very best you can, and to have 3/4 of a century of experience with this is no small feat. And I wondered if I could ask a bit about, you mentioned having to be on quite a lot of this time, having to practice such strong self-management for all this time, and the fact that diabetes doesn't take a break, doesn't take a holiday. I wonder if you could speak a bit about how you've dealt with the, if you've felt tired or burnt out of having to keep on top of diabetes for so long, if that's crept in, and how you've dealt with that.
Now, I get very tired now, but during all the time I had the kids, everybody gets really fat after their pregnancies or during their pregnancies and don't lose weight. I didn't get really overweight with any of my pregnancies, and I was chasing my little children around and I really didn't gain weight, so I didn't have that problem. And then as I got older, though, older people get lots of problems, and I have managed to get breast cancer and had a mastectomy. And I managed to have an angiogram and had cabbage, and that went very well. Both those things went very well. And that was like over 30 years ago, I had my mastectomy, and 17 years ago, I had my bypass, and I'm still doing very well with that. What are you saying, Dee?
One of the things we hear you say a lot is if you control your diabetes, then it doesn't control you. So when she gets, not wanting to poke her fingers when she had to do that with the glucometer all the time, she did it because she knew that if she didn't do it, she would feel worse rather than better.
That's right. And it was always keep your diabetes in as good control as possible, and then you'll feel as good as possible. When you get high sugars, you are really tired. And when you get low sugars, you have no energies, you can't do anything, and life goes on, and you have to be on top of all of that, or else it wipes you out. And right now, I have managed to acquire some esophageal cancer, and that is a bit of a problem. It's quite a problem, but it's in pretty good control. I was treated with radiation, and I am surviving. My doctor told me, just go ahead, eat whatever you want, do whatever. This is the oncologist, of course. He doesn't know anything about diabetes. And I thought, now really, that would be wonderful, but then my sugars would be so out of control. I would be very tired and I just wouldn't be happy. But this way, I am managing my diabetes as well. It's been a little bit touchy sometimes, but we're getting there. And but I am tired. I find myself getting quite tired during the day. But you know what? I'm 88 years old. The heck? I have a right to be tired, don't I?
But I don't think you were ever tired of managing your diabetes. I don't remember you ever saying anything like, I don't want to do this anymore. I think you always
accepted it as a challenge. I got to beat this thing because I don't want it to beat me. And I guess that's maybe hard to accomplish for some people, but I'm pretty optimistic, and I know if I try hard, I can usually win. And I've won lots of times. My oldest son, when I told him I had cancer now, he said, you know what, Mom, I'm not going to believe that you're going to die until I see you dead. You have lived through so many things. I just don't believe you're going to die. So I'll hang in there, you do. And that's their attitude. They think I'm the energizing bunny or something. I don't know. Energizer bunny. But anyhow, that's what else can I tell you? Oh yeah, all the things that come with the older people. Like I've got glaucoma, and I have to check my blood pressure, and I have to take, what other medication am I taking?
Taking furosemide or Lasix.
Right, Lasix, and I'm also having to look after my thyroid, which I got wrecked with the radiation after my mastectomy. And that's what I think, that they say, oh no, older diabetics always get thyroid. I don't think that's true. But anyhow, it's so easy. You take a little pill every morning. And so the things that I have to live with now, I can't forget about. There's a lot of things to take care of. I thank God I still have 2 really good legs and I can walk. I have peripheral neuropathy. And so my hands and my arms, hardly any dexterity in my fingers now. So it does stop me from doing a few things. And I don't see very well, but I can still do chores around the house. They call me the kitchen keeper. I empty and load dishwashers and try to keep counters, and sometimes even cook my own food for breakfast and stuff. So I do the best I can, and that's the way it's going to stay until I can't do it anymore. And I hope that people listening to me haven't been bored to tears. And I hope they do realize that balancing the diabetes with insulin and exercise and diet is just the most important thing in the world. Don't forget it. Don't let it be put on your back pocket. Keep it up front and keep in control of it. And that's the best I have to tell you. Okay.
Thank you, Dorothy. And I don't think any danger of listeners being bored, because it's really a fascinating story. And one other question that I was curious about is living with type 1 myself and having seen, so much change over the last 20 years. I'm wondering if you could share what it's been like seeing all these changes over the decades.
It's been a miracle. Like they're saying they want a cure for diabetes. We have enough technology now that we can look after a diabetes. You get it still, but you can look after it. It's almost like a cure. With this scan that we have now, what's it called, Diane?
You have the Libra,
The Libra.
interstitial glucometer.
You no longer have to just do urine testing to find out what your sugar is. You can actually find out what is your blood sugar, and you know how to treat it so much better. And it's just like a miracle to me, the scan.
Quick scans.
Yeah.
I'm going to add a funny story. When glucometers first came out, they were huge. They were like 9 inches long by 3 inches high by 4 inches wide. And they had blue and white and yellow buttons on. At least the Ames one did. Mom brought the glucometer home because she was one of the very first to use it. And she was trialing it. And she had grandchildren at the time who used to chase grandma to do her ouch, ouch, beep, beep before her dinner. So we knew we had to poke her finger and we knew we had to push a button. And that's what the grandkids learned. Take your glucose with your meals. So you know what you're eating and know what you're shooting up with in terms of insulin.
It was quite cute. The kids got a big kick out of it. And they weren't really afraid of it because I wasn't. And I think that was a good thing for them too. But I don't have anybody in my family that has diabetes, and I'm so grateful the dear Lord has given me that gift. It's wonderful. I hope it stays that way. I have another child coming in January, around my birthday, actually. And I'm looking forward to that too. It's just great having them all together. And my children are just wonderful. All my family, they're good people. They know how to love each other and care for each other. And that's what I would like to leave behind in my life.
And we know how to eat well because we've had a mother who made sure that we loved our veggies and ate proper balanced diets.
That's true.
What other technology we were talking about earlier this week? We took a picture of your first insulin syringe and needle.
Oh my God. That was learning how to do the insulin injections with the stainless steel needles and the glass syringes and having to boil it up before you use it in the morning. That was quite a thing to do too. And I always had an extra one on hand because breaking the glass syringe was not too hard to do after you boiled it. And then you had to keep it, you could use it each day and you had to boil it each day. But when I went in training, there was no a kitchen right handy. I couldn't do that sort of thing. So what we ended up doing was, I think the people that used to make green shampoo had a perfectly shaped bottle that I could fill with alcohol, clean out the syringe after I use it with a little alcohol, and put the syringe and needle right into the green bottle, which was pretty well sealed. And then I'd have it every morning. I could just use it. And all the time I was in training, that's what I used.
Training to be a nurse.
Yeah, training to be a nurse. And then I also have to say that the first 20 years of my life, I was on protein zinc insulin, 1 shot a day, and I didn't have problems. It just was good enough that it kept me, well, of course, couldn't do sugars, and the urine sugars weren't always good, but you had to kind of keep on going and keep on trying, and I did. But the protein zinc insulin was excellent, except it wasn't refined enough. And then they had to change all that. And I think I've been on every kind of insulin that there has been used. The NPH and the Lantus and all of that. And now I'm on Podgeo.
2GO.
2GO. And that's the one that keeps me overnight. And during the day, I take the Humulin insulin, and I take ACPRN as much as I need. We count the carbs and we do the insulin. 1 unit of insulin for every 10 grams of carbs, and it's working well, eh, Dee Dee?
I think it is.
Yeah. And oh, my my oldest daughter is a nurse, by the way. I think you figured that out already. And
It shines through. Yeah.
Yeah, she has invited me to live in her home rather than a nursing home. And I think sometimes she's wondering whatever she did. Every time they tell me I'm going to keep on living, oh, but the
Not
other,
true. I couldn't survive if you were actually in the long-term care facility. I would be going nuts. So I'm happy to have you.
but anyhow, all 4 of my children are very willing to help whenever they can, and they're always here for me. They took me on a big vacation after I found out I had cancer in the summer this year. And they were all here. They were all here on the 3rd of December. So we had Christmas together. And I'm having a birthday in January. And I'll bet most of them will be here then too. And that's the kind of people they are. They're loving, caring. And I thank God for all of that. And I've had a happy, full life. I could get into all my travels and my jobs, but that would take a long time. I don't think people really want to hear all of that.
Well, I think, Dorothy, at the least, it's really apparent how wonderful of a support system you have, and how you practice a lot of gratitude for what you have. And I'm wondering, we have some questions coming in, but I wanted to ask quickly, Dr. Tessier, what you think the audience might be able to learn from Dorothy on approaching their self-management of diabetes later in life. What lessons are showing up for you? Oh, you're on mute.
What I find interesting, Mrs. Bergmann went to Jocelyn Clinic when the for initial treatment. Did I hear right? You went to the Jocelyn Clinic in the United States.
Thank you.
Actually, came up to the in Toronto.
In Toronto. Yeah, actually, what I think is that every patient, type 1, type 2, young, old, should be well treated for his diabetes as soon as possible to prevent complications.
Yes.
So that's what I'm listening. Probably you well treated to start with, and you carried this good treatment for your whole life. So, and I think you were quite motivated. What I hear, you never abandoned the treatment of your diabetes. Sometimes we see patients who do not take their medication, do not test their glucose, they come with high sugar, complications, neuropathy, heart disease, and it's too late. It's too late. And in general, in diabetes, an ounce of prevention worth a pound of treatment. I think you're quite a good example of how it's important to control your sugar, keep motivated, have physician, nurses, pharmacists around you that stimulate your interest to have a good care of your diabetes. You know your HbA1c? What is it? Did your doctor say, well, your HbA1c is 7%?
It was 8.1 last time. And my oncologist, not my oncologist, my endocrinologist that looked after me for about 35 years, said to me when I was doing these, he said, look, Dorothy, you're over 80. You can have an 8 and don't worry about it. So I said, okay.
Look, but probably it's important. You may start to be diabetic at 8 years old, but the majority of the population I see, they've been diabetic for 30, 40 years. And when I see them, I think the things are done and complications are there or not there. And I try to keep in line with what they used to do for their whole life. If they're being compliant, HbA1c 7%, perfect, we'll go for it. If they had poor treatment their whole life, it's a little bit difficult to convince an older patient to change his dietary and monitoring habits. Well, congratulations. I think every diabetic Canadian should be well treated like you.
I'm sorry.
He says, congratulations. He thinks every Canadian with diabetes should be well treated as you've been.
Good. Thank you. I agree. I've had some wonderful care and support from my mother and father and my husband and my family. And I've just been a very, very blessed person, and I'm grateful. And that's it.
Yeah, thank you, folks. A question that's come in from the audience is, and I'll pose it to both of you. I'll ask Dorothy first, but Dr. Tessier, if you have anything to add, feel free. And it's this person's wondering how Dorothy, how you managed going through menopause, because this person is going through it now and feels that they struggle to connect, why their sugars are doing what they are, and they've lived with type 1 for 47 years, and they're not sure how to figure out these patterns.
I cannot help them. I had a mastectomy complete, and I didn't ever have menopause.
Your chemotherapy caused artificial menopause, so
that's
she
right.
never went through the stages of perimenopausal
Yeah,
problems with control.
and I'm watching my two daughters now, and they're going crazy, but they're not diabetic. They don't enjoy menopause at all. And I'm grateful I didn't have to go through that. So it's and I think it is just because I had the breast cancer and the
I think well, they said the chemo wiped it out.
Yeah, that's true. Yeah, in those days with the breast cancer, they did surgery, and they did poison, and they did radiation.
Cut, poison, burn.
Cut, poison, burn. That's it, and that's what they did. And that was well over 30 years ago, and I'm fine. So there you go. I'm again very grateful.
Dr. Tessier, any advice?
I was thinking of if there's any studies of how menopause influences glucose control. I don't think it should have a major influence on doses of insulin or drugs you take, but I would say just keep going with the best control you can aim for. Have the best sugar control. If you go for HbA1c, 7% or below, even 8% in certain situations is correct. So just keep an eye on your sugar. Don't say, I'm getting older, so I don't have to look after my diabetes anymore. That's false. I think it should be an issue all over your life.
Yeah, that's right. It's your challenge for your whole life, really. And
what I'm impressed, Dorothy, that some people say that, well, I'm diabetic, I've been punished because I ate too much ice cream, I didn't do the good thing. So we try to take away this raisonnement, this way of thinking, and say, no, I think it's a health condition you have to treat, take in charge. There's a solution, many solutions. There's been fantastic development in drug treatment. So try to have the best treatment you can have for your sugar, as your blood pressure, your heart condition, and all your health conditions.
Yeah, don't let them go. Hang all the pieces up there together and hang them out to dry. Keep them going.
I have a couple more questions, folks. One is specific that we've already answered, and it was a specific one about asking if Dorothy uses a pump and a CGM. So sounds like you use a CGM and multiple daily injections. So just for reference for that person. And then we're coming up on time. We only have an hour, but I see a couple of questions. The last one I want to ask is to Dorothy, and this question is, what has been your main motivation during all these years? And you've touched on it, but I'm curious what you describe that as.
Motivations.
I think the love that has surrounded me has given me the motivation to keep on going and to remember this is a challenge. You can beat it or it can beat you. Keep on fighting. I think that's what I have to say there. And what was the question about the pump? One of the graduate nurses, there was 3 of us that graduated around the same time. And the first one, as soon as the pumps came out, right onto the pump she went. And she lived with the pump for all the rest of her life. She died at 78. Now, it was not from her diabetes. I'm not quite sure what it was from, but she was a wonderful nurse educator in London, Ontario. Her name was Dorothy Gibson, and she really was the first diabetic to become a nurse in Canada. And I was very, very sad when she passed away, but she did the best she could, but she swore by the pump. Now, I have seen lots of people, they tell you to change your injection sites all the time. Well, the pump is inside of you and it's in the same place for 30 days or something like that. And I do think that I have seen lots of people who have had ulcers and they just haven't been able to manage the pump. I would have nothing to do with it and I still won't.
Yeah, but the pump is progressed in its technology, it's much better, and insulin is much better too. So staying in that same site isn't as big a deal. But I think what you've done, Mom, is you've taken control always. And
The pump doesn't allow
The
you to have
pump-
that same
Yeah.
control.
she was scared of the technology of the pump failing and not then having the control.
Yeah.
I think one of the other things, quickly, we grew up with a poster in the kitchen on the cupboard that said persistence and determination are omnipotent.
And
That's where my mom's motivation comes from too.
Yeah,
Mm.
that's right. And I did make the kids understand that. And I think they all do. So it's good. As I say, I love my family. They're wonderful people. And they are. They're good people. That's the
He
important
needs to
part.
finish that.
Hmm?
Enough of that.
Well, I think it really shows, Dorothy, and I want to say we're going to wrap it up. I hate to hit pause on a great conversation, but I just want to also say there are a lot of comments sharing just how amazing our viewers have found you and your story, Dorothy. So thank you very much for sharing.
You're And thank you so much for giving me the opportunity to, I guess I'm bragging a little bit, eh?
I think you can after this much experience. Feel free to brag a bit.
Thank you so much for everything. And thank you for all you are doing too, to look after those people who need your help. All of you. Thank you.
Thank you. To our audience, if you have, there are a couple questions we weren't able to get to. If you'd like to reach out and get an answer, please feel free to call 1-800-BANTING or email info@diabetes.ca. And you can also follow along at Diabetes Canada on social media or diabetes.ca to keep in touch with our tools and resources. I want to just give again a huge thanks to our guests, Dorothy Bergmann and Dr. Daniel Tessier, for your time and your sharing today. It's been really valuable. Personally, I've really appreciated this conversation, and I hope that I'm confident this has been really, really helpful to our audience as well. So to everyone, thank you so much and take care.
Thank you.
Thank you.